Every step matters. Paw Patrol. Paw Patrol. Paw Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Paw Patrol. Paw Patrol. Paw Patrol. Paw Patrol. Every step matters. Paw Patrol.
All right, welcome into Paw Patrol with your host, Dr. Jeff Dikis. Today, I'm doing a very special live on location from the Wisconsin Foot and Ankle meeting in Milwaukee, Wisconsin. Thank you to the committee for having me here to perform this live Paw Patrol podcast. I'm joined by Dr. Scott Carrington, faculty at LaCrosse, Gunnison Lutheran, one of the best residencies in the country, in my opinion. So thank you, Scott, for joining me.
Yeah, students come out and rotate with us, right? We've got residents out here too. It's great fun.
Absolutely. I'm a big fan. I originally was going to do this with Brad Avix, my co-host from the Gatekeepers Journal Club podcast, but he got scared. And so he had to send Scott in his stead. Brad is one of Scott's partners. So hopefully we're going to have some fun today. For anyone who doesn't know, my name is Jeff Dikis, and I do host the Paw Patrol podcast, Gatekeepers Journal Club, and the MIS Adventures limited series on minimally invasive surgery in foot and ankle. Those are all available online. I am clinical faculty from Des Moines University. My wife teaches at Des Moines University. She's the clinical director of Des Moines University Foot and Ankle Clinic, for anyone that doesn't know. I work for McFarland Multi-Specialty Clinic in Iowa, the largest in Iowa. We have over 280 providers. So these are the things that we're going to be talking about today. So I want you guys to look at this here real quick. Everyone get their phone out, and we're going to vote on what we're going to talk about here. And if not enough people vote, then I'm going to pick, and it may not be the one that you want to hear about. So we're going to break down some topics here. Scott and I are going to go back and forth, give our opinions on these. Achilles Haglund, open or MIS. Achilles tear, minimally invasive repair versus non-op. Ankle fracture, fibular plating versus nailing. Ankle fracture, fibular lag, screw or no. And fix the deltoid or the syndesmosis. So here in a minute, there'll be a QR code. Everyone can get their phone out, scan the QR code, and vote for what you want us to talk about. While you guys are voting, I'm going to talk a little bit more to Scott. So Scott, tell everyone where you went to school, where you went to residency, and where you currently practice.
So at school at Des Moines University, I was a year behind Jeff. So I knew Jeff in school. I trained out at Harms PSL in Denver, Colorado, and then fellowship out of Pennsylvania, including health. And I've been back, practicing LaCrosse for about the last 6 years. I was in practicing Colorado for a while and got booked in to move in the Midwest.
Absolutely. So you're a faculty at the LaCrosse program there, and I went and visited last year, and you guys were kind enough to invite me to speak at your conference. And it's a phenomenal program for anyone who is listening to this podcast. I get lots of listeners who are students. So anyone who's listening to this podcast, go check out the LaCrosse program. It's fantastic. The residency director does happen to be one of my best friends and the person that I met first in podiatry school, Devin Simonson. He actually introduced me to my wife in the cadaver lab. That is not a joke. He introduced me to who would become my wife eventually in the cadaver lab. So we're still happily married. So thanks to Devin for that.
And Devin's our current residency director and does a great job with the residents. So
Absolutely. So we got a tough battle here, but it looks like we're going to go with fixed deltoid or syndesmosis for the first one. All right, so these x-rays I think are similar. When you're a younger person and you look at these x-rays, you start to think, oh, there's something wrong with the ligamentous complex of that ankle. But what? Scott, what are your first thoughts when you look at an ankle, and what are the differences that you notice between these two ankles in terms of traumatic insult and how you're thinking about approaching these?
Well, so the one on the left, is it there left? The one on the left is clear to me. You can see a bulging fracture off the median tailor. So this is clearly a deltoid injury to me. Even though there's lateral translation to the talus with the bulging fracture automatically cues me in on there's some deltoid insufficiency and some deltoid problem. You can see there's maybe a small bulge. I don't know if it's just the x-rays in the McFarland clinic that are that bad and testing into that fuzzy, but there's possibly a deltoid inside there because it's more of a tilted talus as opposed to a lateral translation in the talus.
Yeah, so you bring up a very, very good point, and I try to teach the students who rotate through with me. These are similar but different injuries in terms of lateral translation of the talus and that distal. There's a small transverse distal fibular fracture that's allowing that on the translation of the talus on the left, and then the talar tilt that you see, but the syndesmosis does not seem to be disrupted in the image on the right. And so this is an interesting conversation that I've had in many an online discussion, is when we tackle these traumas and we know, okay, well, it's easy. We've got to fix the bone, put the bone back together. That's pretty simple. That's early on stuff. But from a ligamentous and a dynamic standpoint, do we need to fix the deltoid in addition to the syndesmosis? Or by fixing the syndesmosis, is the deltoid subsequently reapproximated and we don't need to fix the deltoid? I think it's an interesting thing to think about. If anyone does enough trauma, which I do a decent amount of trauma, when you fix the fibula and you put everything back together, you test it, it's unstable, you fix the syndesmosis, and sometimes you get some residual talar tilt and sometimes you don't. And I don't have a good understanding or theory of why some cases remain more unstable after fixing the syndesmosis and why some don't. I think there's some kind of deep, dark, hidden secrets from the deltoid complex, whether that's superficial components, deep components, which components are actually torn, as to whether the indirect repair that's deltoid is accomplished by fixing the syndesmosis. What are your thoughts when you tackle a trauma and you're looking at syndesmosis, the deltoid? Do you fix it? Do you not? Do you test it? What are your thoughts?
So we're dealing everything ahead of time. Do you have post-op films on these?
No.
Okay,
Not on these
that's
specific
fine.
ones.
So what I would say is the one on the left, if you fix the fibula fracture, stress it, and fix the deltoid or fix the syndesmosis, that talus may be aligned and it may still look stable. But I would argue the large deltoid insufficiency injury like that, you are going to have residual problems down the line with the ankle if you don't address the deltoid and injury like that. And that's where I think we can get fooled, where we can stabilize the syndesmosis, the talus goes back into the mortise, it doesn't look like it's laterally translated anymore, we stress it, and it looks stable. And I just have a hard time seeing these down the line where you start to see residual varus tilt of the talus because the deltoid was not addressed.
Yeah, and another thing that I like to teach the students is that x-rays are a static image of a dynamic thing. Your ankle is functioning, it moves. We're getting a static image. Same thing with MRI. The only way to test that, for the most part, would be intraoperative fluoro to see what happens when you stress something. You can get some in-office stress fluoro exams. Your patients won't like you very much because they're tugging on their ankle that, they tore something, but intraoperative fluoro is most important. So fixing a stepwise approach, fibula, syndesmosis, test the deltoid, talar tilt, you're going to want to fix that. Because
so how are you testing the deltoid after you get stabilized?
So it doesn't lie to you. And so when you fix the syndesmosis, or at least when I fix the syndesmosis, and I just do a talar tilt sign, I just take the hind foot, stabilize it, lock it, and evert, it's going to either open up or it's going to be highly stable.
Okay. I would agree and somewhat disagree. That's what we're supposed to do, right?
Absolutely.
So I think the best intraop test that we see with the deltoid blading is not a lateral translation stress test. It's an external rotation of the ankle under live flow, because what we see even in cadaveric studies and long-term studies, that externally rotation stability of the ankle is what we see when we have an insufficient deltoid.
Yeah, that's a great point. So it's not a simple side to side. There is an external rotation component to that as well. How do you test the syndesmosis? Because I'm one who admittedly will pretty much fix any syndesmosis on any trauma. And the reason is if you neglect the syndesmosis and you see it in your office later, it is an absolute nightmare. You're going to wish that you took an extra 5 minutes and stabilized the syndesmosis. So a neglected missed syndesmosis is a huge train wreck, and the 5 minutes it took to fix it are well worth avoiding that. So what are your thoughts on testing syndesmosis? How often do you repair it, and neglected syndesmotic injuries?
Yeah, I mean, it's the same test. I'll do a lateral translation full test on it, but then I also do an external rotation to also test the delta at the same time. So here's kind of what you're seeing, right? You're trying to do your tilting and opening the mortise there. It's looking at your lateral ligaments, but also your syndesmosis. But I agree, it's a very simple last-minute step on fixing a syndesmosis, and you would bet it long-term, because an unstable syndesmosis acutely causes more problems than what you see with a deltoid that's neglected. Those tend to be more chronic problems.
Yeah, absolutely. if you've ever done enough trauma and you missed either a syndesmotic injury or a deltoid injury, and they come into your office and you start to see that talus tilt or start to see it laterally translate, you kind of get a pit in your stomach and wish that you kind of stressed it a little more intraoperatively. And so I think taking your time intraoperatively, you don't just fix the fibula and then look at the x-ray. Oh, look at that mortise. It's fantastic. I'm done here. You have to then put it through its own rigors and test it and make sure that it is stable from that standpoint. So this is a case where I do have some post-operative x-rays. What are your thoughts on this type of injury coming into your clinic?
Thoughts of the residents are going to be happy because we're going to fix something. But this is a clear indication where even just radiographically, I can tell you that there's both the deltoid and syndesmotic component to this injury.
And that's where this is an interesting concept, because if you look at this radiograph, I would 100% agree with you. But I did not fix the deltoid. And am I wrong? I think that's where we can learn from these things is I fixed the fibula, I fixed the syndesmosis, I look at that ankle joint on x-ray, it looks fantastic, and I stress it, and it doesn't have any talar tilt or any abnormality to it. But 5 seconds ago, I looked at that x-ray on the left and I thought, well, the deltoid has to be insufficient. So is stressing an ankle after fixing the fibula and the syndesmosis that doesn't have any residual talar tilt, is that enough? Are we done? Or is that patient at risk for long-term complications because looking at the x-ray on the left, you know that there's probable deltoid insufficiency?
Yeah, and we know, when we look at literature 20 years ago, when the deltoid was just left alone, because we could realign the ankle with the syndesmotic repair. And so we felt, all right, it's going to heal on its own. But what we saw as we follow some of these fractures long-term is that we start to get into growth wear of the ankle because the deltoid didn't either heal properly or there's just continual residual tilt to the talus that we're not seeing. So I was still with this injury because clearly if you have a deltoid rupture, if that much lateral translation out of the mortise, I would still open this up and primarily repair the deltoid.
So what is your technique for a deltoid repair?
So it's a simple intraoperative repair. It's just a linear incision or curvilinear incision like that. If it's an acute rupture, and most of these ruptures on ankle fractures are usually some sort of a sleeve avulsion where you can just primarily suture it back together. The other extra, that last injury you showed me, I think he may have a lot of tissue insufficiency, and so it would be consideration for an augmentation with deltoid repair.
And when you say augmentation, we're not going to say trade names, but it just mean like a suture tape type.
Suture tape or a bioinductive band. Yeah.
Yeah. So this is a separate case, but this is demonstrating a deltoid repair and how simple it can be. So this is in the purple is probably not quite as big as it would be, but kind of you can see the historical kind of open deltoid incisional approach versus the smaller incisions that I utilize. And even now I've combined it down to one small incision. So you just made one small incision over the medial malleolus. I insert an anchor into the medial malleolus that's seen there. And then that top right image is looking at the anchor drill bit into the talus, into the medial aspect of the talar body. And I use tensionable ball suture anchor. So I lock one tail of one stitch into, so the tail coming from the talus is getting locked into the whip part of the medial malleolus and vice versa. And it just kind of cross locks those down. And I can do that through a very small incisional approach and seems to get good stabilization. What are your thoughts on if we repair quote unquote the deltoid? I think that we kind of undervalue the deltoid, meaning there's multiple components. There's superficial, there's deep, there's a spring ligament component of that complex of the ligaments medially. Is a simple medial mal to talus anchoring system enough to quote repair the deltoid, or do you think we need to be more aggressive, or what are your thoughts on that?
I think in an acute injury, yeah. So if this is acute traumatic rupture of the deltoid, initially I think this is always sufficient. In chronically insufficient deltoid, this isn't sufficient.
So how about that? So that's when you're augmenting and you're kind of opening up and
augmenting and doing, bands in different locations, indicating on spring ligament repair. So you're going to assess some taculi. So you can address both the deep and superficial components of the deltoid.
So I was going to say, when you're augmenting, are you going medial malleolus to talus and then medial malleolus to substentaculum, or are you kind of going one to the next?
Yeah, no, that's exactly what I did. If we really need to get strong with it, then you wrap it through the navicular alls to include your spring and repair everything.
And so would that be kind of a progressive adult acquired flatfoot, a posterior tibial tendon dysfunction, someone that's got chronic medial insufficiency that you're talking about specifically?
Yeah, progressive collapsing foot deformity.
Yeah. So when we talk about that, you know, we're going to go down a different pathway here real quick. But when you address the progressive adult flatfoot deformity, do you think that we need to address the deltoid, or do you think that by fixing the biomechanical reason that the deltoid is insufficient, i.e. the flat foot, by correcting the flat foot, whether it's a triple, a double, whatever, do we still need to fix the deltoid in those patients?
So that's another instance where I was stressed the intraoperatively after repair. So let's say we're doing a tenonavicular subtalar joint fusion for a significant percent of what's flat foot. After it is stabilized and we've got the joints in place, then I would stress the deltoid, because the problem is you will see it long term is if you have really progressive flat foot and you stabilize it fit down the line, they come back and you start to see more valgus alignment than anything because the deltoid is insufficient. So it's another one of those intraoperative stress to see if you do that in there.
So not too different from a traumatic setting where you're fixating, then stressing, fixating, then stressing.
Yeah. Right.
So we kind of talked about this, stressing the ankle. What about the AITFL component? So that's kind of been in vogue recently, the anterior inferior tibial-fibular ligament. I'll make sure I say that correctly. What are your thoughts on addressing that? I had Bob Anderson on one of my podcasts one time, who, if you don't know, I'm sure everyone does, is an NFL doctor, a foot ankle orthopedic surgeon, and was very kind of specific to look at the AITFL from that standpoint, because if you have insufficiency of either the posterior or the anterior and you try to reduce your syndesmosis, you can get malrotation of your reduction. And so stabilizing the AITFL separately from maybe your suture button across the syndesmosis was something that he was adamant about. I'm not as adamant about that, but what are your thoughts on primary repair, direct primary repair of AITFL separate from your syndesmotic injury?
Yeah, I mean, the literature talks more and more about this, and I have yet to really integrate this into our fractures. When you were doing the fibular fracture itself, open, that's another debate maybe. You stay right at the AITFL, and if it needs to be there, you can go with you there. But I do agree. I mean, I've heard Dr. Anderson talk about that, the rotational component of it. I haven't done it yet. It's probably something to be looked at and probably worthwhile, but I also don't treat athletes outside of the farm league.
Okay, so we did.
It's a farm league.
All right, so everyone get out your phone. This is a QR code. Vote on who won the debate. We didn't really debate anything.
Yeah, we didn't debate much on that one.
All right, well,
so you can give it to me.
All right. Well, let's go ahead and check and see. Oh, wow.
100%? 100%. Is it only my residents in Bonneville?
100% is not here. Fantastic. All right, if you can click that hold button, and then we're going to jump ahead to the next.
Can you screenshot that? Can you screenshot that?
At the very bottom, there's a button that says clear results. If you hover over that, in the middle, like go down. It should pop up. You might have to click that. I don't know. All right, just yell out some things. What do you guys want to see from a topic standpoint? There it is. Oh, it doesn't do anything. So you can get that back and get clear results. So what are your thoughts on us treating all right, anyways, let's just move on. Anybody yell on the topic do you want to talk about? Achilles open, or do you have a preference? What do you want to talk about?
No, I don't.
Oh my God, that was the one I was hoping to avoid, right? What do you do? Lapidus or MIS stuff?
I can't throw a bunion in my practice because Dr. Endick's there. He has them all.
He has them all up.
No, so I am not huge on the MIS huge shift bunion yet. But I think that's an interesting debate. What do you do? I know they were probably in the same camp as me, but what do you do for a large shift bunion? a large shift of 110% of that head, or do you address it at the TMT?
Yeah, I'm a big Lapidus guy. If anyone's ever heard Brad and I argue about this, he's a head guy for the most part, although he does some Lapidus, but I do a minimally invasive Lapidus. Let's talk about Achilles open versus MIS, and then we'll do the bunion at the very end. So let's go to Achilles open versus MIS. So we're specifically talking about a Haglund's deformity. I don't think there's any debate anymore about an Achilles tear. We're tearing open versus minimally invasive approaches, and I know you would agree with that, so that's not much of a debate. But how do you fix your Haglund's repairs? Are you doing open or minimally invasive approach specifically for the bony problem?
So we're doing all MIS now.
And that makes a whole lot of sense to me. From a show of hands, how many people fix their Haglund with an open approach? And I guess the opposite would be who does it via MIS approach. So this is kind of an interesting thing where, technologically speaking, we are constantly evolving. AI, 100,000 different things we can talk about. But when it comes to foot and ankle specifically, we'll focus on that. There's constantly emerging technologies that are coming out and different ways of doing things. When a new technique comes out, how quickly are you someone to adopt that new technique and try it versus not? I know what I know. I've been doing this 100,000 different times. I have good patient outcomes. I'm not looking to adapt.
Yeah, I used to be early adopter in a lot of things, and now I like to really see how it pans out. Well, done in some things. That's why I haven't been an early adopter on bunion. But I think there was a point when we look at minimally invasive procedures, can we really improve outcomes by adopting those early? And the Haglund is one of the first things where I started diving into minimally invasive approaches. We obviously, with an open Haglund, you can see everything very, very well. You can clean it all, but there are incisional concerns. I mean, you can look at the exposure. You can see everything. As a resident, this is also really, really fun procedure. I love this procedure as a resident. It was a great procedure. It was very fun and satisfying to rip that off and then do your double or single row repair. But then as an attending, I got out and I realized how much the patient's actually getting recovery from this procedure. And then I also saw incisional wound problems.
Yeah, it only takes one or two incisional wound problems to wish that you hadn't have done that. And I've done it before where when they come in and I'm looking either at tendon or I'm looking at the suture material that I used to reattach the tendon back to the bone because they had a suture reaction. It's just not a fun day in the office. Do they heal up eventually? Yeah, but it's just an added nightmare for the patient. They kind of scar down. Once you kind of don't get that reapproximation of that tissue back there, that makes you a little nervous for future week because you start taking out chunks of tendon. That's a different talk I have on addressing that. But yeah, when we do this open approach, I always say that there's two components of this. What's better for me and what's better for the patient. This one's better for me. I have good visualization. I can see everything that I need to see. I can know that I've resected all the bone. I have direct visualization of everything. But from a patient standpoint, if someone gave you the option, hey, do you want me to fillet open your heel so I can see everything? It's going to take longer to heal, the increased risk of complications from a wound healing standpoint. It's not necessarily better from a patient standpoint. The one caveat to that I have got some pushback on after adopting the MIS approach is, well, I go in and I take out all the bad tendon. You can't take out all the bad tendon through a minimally invasive approach. What do you think about that?
You can, 100%, because I do it. We just did Wednesday, right, Levi? So we had a recent patient with significant intratendinous calcifications. And where I make my portal of the burr is right up the intratendinous calcification and then the disopathy. And you can burr out the calcifications on the back of the tendon, and you can also go in there with the pituitary rondure and remove the calcifications within the tendon itself. My take on the MIS approach, the way we do it now, we're still able to address the pathology of the tendon, but we largely leave the native attachment in the Achilles intact. My guesstimate, and my resident brought up this study, and maybe you should look at this. My guesstimate is we probably preserve 8% of the attachment of the Achilles tendon with a minimally invasive approach. And so you're not significantly weakening the attachment of the tendon into much more robust repair. We still augment it with suture anchors, but you can address tendinous pathology through a minimally invasive approach.
So I agree with you. You can also scope it. You can do tenoscopy. You can stick a camera in there and you can use the aggressive shaver and debride the tendon if you'd like to. And I'll show you pictures of that here in a minute. But I think we're going to have our first kind of disagreement here. So I think that when I am trying to resect the posterior aspect of the osseous material back there, the adhesophyte, that I'm perfectly fine with detaching the tendon. In my experience, if you get enough bony resection, you can feel the tendon release off of the bone. There is no retraction of the tendon because it still has the peripheral fibers medially and laterally. But one of the reasons I'm okay with fully releasing the tendon is the same biomechanical theory is not even really theory, it's been proven of why the Zadig osteotomy works, because you're decompressing it and you're effectively shortening the Achilles and anteriorizing it, which if you do that here, you can see on the original image, the Achilles is going to be attached posteriorly and inferiorly, and after resection, just by nature of where you're going to put your anchors, the tendon attachment is going to be more superior and anterior. So that effectively helps with the underlying equinus deformity, maybe the etiology of why this, some people are born with just a true habit of deformity, but some people have that calcification and that chronic thickening of the tendon that may be due to underlying equinus deformity, where I feel like I can address both of those through one procedure without doing a gastroc recession. What are your thoughts on that and the necessity of a gastroc recession in conjunction with this?
So I don't do a lot of gastroc recessions with these after I do the Brandon because they usually have good range of motion. It's also a test preoperatively as well. I have a big problem with gastroc recessions and tendial Achilles lengthening, probably to a fault, because my residents give me a hard time probably in the back when they're in the room talking about me. But I do not like weakening the posterior muscle group. I think it increases rehab time. It's harder to return from. And I fall in maybe this small camp in the podiatric community that I don't think equinus is the root of all evil, because I don't think it's there as much as we think it's there.
So I agree with you to an extent that I don't think we need to do a gastroc recession with this procedure. And we don't need to necessarily touch the tendon. The same concept is true, like I mentioned, in the Zadig osteotomy, where you don't have to touch the tendon. You're just moving the kind of function of the insertion of the tendon and getting good outcomes from that standpoint. I've had Tyler Gonzalez on a podcast before, who has written almost all the papers on MIS Zadig osteotomy. So this is a very kind of straightforward procedure. If you're used to doing any MIS, it's just you're using the MIS burr, you're going through some portals, you're resecting some bone, and you're checking it under fluoro. I like the big C on here. You can just put in a lateral view. It's very easy. They push the button for you. All I have to do is worry about resection of the bone. Do you have any techniques here for ensuring enough resection off the bone, or how do you position your patient, and how are you what type of C arm are you using?
So we do it similar setup, but I use a mini C. So you have to rainbow the mini C over the table. So it's kind of an awkward setup. But I did enough radiation in my other surgery, so I try and keep it smaller in this one. And the resection is, you're kind of rotating the foot around during the fluoro to see, but a lot of it is feel. And that's what I've learned with MIS. It's a very different kind of technique because a lot of it's feel. So you're feeling the calcifications, you're feeling the anatomy of the bone as you're dividing. And then like you do here, you squeeze it all out and you can see how much you decrease the posterior prominence of the heel and how much you now just have this dell of tissue that's there.
It's so satisfying. It's like pimple popper MD, where you just start squeezing it and all that stuff comes out. That's all that bony material that you had just resected. So some people don't necessarily try to squeeze that out. I do try to squeeze that out, flush it out, get it out of there. You're putting your anchors in. I'm sure there's different systems on the market. I'm not here to talk about any specific system, but putting those wires in good placement. What are your thoughts on the people who say that these posterior calcaneal anchors cause irritation or like stress rises at the posterior aspect of the calcaneus?
They cause irritation, then you didn't bear enough. But you do see some ongoing bone marrow edema pain if you get an MRI. Some of these patients, and we see it with our Achilles approach that we put anchors in, sometimes that is a complaint with the heel still hurting. So it can cause some stress reaction with the heel. It does resolve, but it can take a little longer.
I agree. And so what I have found is that if you are ensuring that your proximal row of anchors are angled inferiorly, that you have less pull of the construct between the suture and the anchor at the bony interface. And so if you just go straight in, the construct is coming more at a right angle, that's going to induce more stress and toggling. Whereas if it comes down and you kind of go down at a 45-degree angle, there's less stress on those proximal anchors. I haven't had any issues with this. These patients are so happy they get back into their regular shoes. I had a guy that went back into his regular shoes at like 3, like before I even took his stitches out, and he wanted to go for a run. He's like, feels great. Can I go for a run? I'm like, I don't know. Like, I'm pretty new to this.
She jumped off the clinic table at 2-week post-op, jumped off. She's so happy. And I said, whoa, don't push it. She goes, it's just fine. But again, my argument is I feel like I keep most of the tendon attached. Now, we do have one interesting patient we're following. We did a Haglund's, open Haglund's on her about 18 months ago. She absolutely loved it. Thought it was amazing. She, through a friend of hers, found out that we do a minimally invasive approach now. And so she wanted the other one done minimally invasive. And I always hate that because she has such good outcomes with the other one. But we did that on, she's only, I think, maybe 2 months out, 3 months out from the minimally invasive. So that'll be an interesting case study within the same patient, open on one side, MIS on the other side.
It's like when a patient comes in and they have like a scarf on the other side. Like, I want the same thing. Like, well, you got to go find that guy because he's probably good at scarves. I'm not your scarf guy. But yeah, when they want like something done differently, or they're also this patient, I think, had both sides done, and the first side went perfectly. Oh, that feels fantastic.
My model is the worst.
You do the other side, and you're like, okay, I hope it goes just as well as
they always need care the rest of their life on both sides. Yeah,
exactly. So I'm a strong proponent of testing your anchors intraoperatively. That's true with any anchor. If they're going to fail, you want them to fail intraoperatively. On that first video, it went by quickly, but you want to test those, pull on them rather hard, then test your Thompson test. If you don't release the entire tendon, then of course it's still going to be intact. And especially if you aren't aiming to reflect or resect the tendon, even from the central aspect. And then this image on the right looks like a snot rocket that one of my sons, like, we don't, that's kind of gross, but this is the inside of the attachment of the Achilles to the bone. So I marked it out, Achilles, suture, anchor. I wanted to kind of see what was going on in there, so I stuck a small scope in there to look around and see what I was doing. This was my very first case that I did. And anytime you do something for the first time, even though I had practice in the cadaver lab, you're a little nervous. Like, okay, did I do all the steps correctly? Did I do this? I want to stick a scope in there and kind of look around and see, okay, yeah, those anchors are definitely flush, if not deeper to the surface of the bone than they need to be there. So do you scope the posterior aspect when you do this? Do you debride with aggressive shaver? Do you do anything from that standpoint?
No, I don't put a scope in there after. When I used to do just isolated calcaneoplasties and gastroc, which I think is a good way to approach a large patient that has diabetes that can't undertake this, then I think calcaneoplasty and gastroc, they actually do pretty well with. It's the only time I consider doing gastroc. That's the only time I put a scope in it.
And so is open still a viable procedure? We're not trying to offend anyone here that voted that they still do it open, but it's always interesting to consider these things from a medical legal standpoint. And you have to understand the impression or something that even lawyers or the general public is going to have. If you do an open and it fails and they find out about this minimally invasive approach, are they going to come after you and say, doctor, did you know that there's a better way to do this? And you still did this old way of doing it. I play devil's advocate. Obviously, open seems to be okay. But from that standpoint, what are your thoughts on, as technology advances, if we aren't doing the latest and greatest, especially if the research is out there that shows in direct comparison, well, this one's better and you still chose the old version. What are your thoughts on that from a medical legal standpoint?
I mean, I think open and MIS, I don't know what term my wife is, and maybe she'll sue me later, but
you're cooked in a divorce.
Yeah, I know. Yeah. I just give up. If I'm divorced, I'm just moving somewhere else because I have nothing. But I don't think that'll be a debate, because in anything that we've seen, when joints go MIS, there's still open approaches. There's still literature that supports both. But I think the question is what's right for the patient. Open, I still think is a very viable approach to this. There's nothing wrong with it. And even over time, my open approach got smaller and smaller. I used to do the big lazy S incision, and then it turned into just maybe, a 1-inch incision where you can still address it in an open fashion. But I also think from a technical standpoint, in part of the residence, I think we still need to open these things and so they can understand anatomy and understand dissection on these.
All right, we're gonna give people one more chance to vote here and see who they vote for. Go ahead and vote if you haven't come on yet. Scott Carrington, 100% vote. Fantastic, 100%.
I don't think again, we kind of agreed on that one.
You're starting to figure out that those votes aren't really being counted. Let's do this here real quick because it popped up, MIS versus non-op, because this is, I think, one of the most interesting things that is coming out. If anyone knows who Lyndon Mason is, he is extremely well known worldwide out of the UK. Very, very well published on posterior malleolus fractures and Achilles stuff. He is brilliant. That does not stop me from getting into arguments with him on LinkedIn about things that I disagree with. And one of the things that it'll be on the next slide. Let's set this up here real quick. We have about 10 minutes left. And then we'll talk about what the research shows from a non-op standpoint. So Achilles tear, minimally invasive versus non-op approach. 19-year-old college basketball player. Hemorrhagic complete Achilles tendon rupture, proximal stump. So first question is, do you get an MRI on all of your Achilles tendon rupture? Someone might say, of course you don't need it. Thompson test has failed. You could feel the death. Let's go to surgery. Do you get an MRI? If yes, why? If not, why not?
Normally I don't.
Why?
Because it's ruptured.
Correct. So my argument would be, and if you're going to do this, so I already know what your answer is, and you can expound upon how you do your minimally invasive approach. But when I do my minimally invasive approach, I'm not using ultrasound, and I want to know where the proximal end of that stump is and how big the defect is so that I can plan my incision accordingly. You think that you know, you run your finger along, and I made my incision not quite in the right place before. You got to extend it up or down a little bit, which is another reason why I make a vertical incision. We'll talk about that here in a second. So talk to people about how you do your minimally invasive approach and why maybe you don't need an MRI, but I do.
Yeah, so that is one of the reasons I don't get MRIs anymore. One, I like to fix it. If we have an Achilles rupture, I like to fix it very quickly within a week time frame because I think you still have viable edges there. You've got a healthy phenotype at that point. If it goes going chronic, it retracts more, the mop edges become unhealthy and you got to resect more. So that's one of the reasons I don't want to turn around from the MRI. Second is I visualize the tendon intraoperatively with ultrasound now. So I know exactly where the proximal stump is and where the rupture is because of the direct ultrasound visualization.
Makes a whole lot of sense. So this is some of the research that's coming out here. You can see Lyndon Mason on that first study here, looking at functional rehab for Achilles tendon ruptures. And so what they have shown recently was that aggressive early functional rehab had equal outcomes to surgical fixation of Achilles tendon patients. And I was getting into arguments with him. We don't need to go down that path, but when I had said, well, what about elite level athletes? Are you still treating them non-operatively? And he said that he would treat everyone non-operatively. What are your thoughts on that?
Yeah, I mean, they've got there's a good data set, and I can't remember if this paper mentioned that too, but they have soccer, I guess we call them footballs over there, right? They're treating these high-level football players non-operatively, and they're getting back to play. Whether that came about because of the socialized medicine, the way it's set up over there, that they treat a lot non-op, but they are having pretty good outcomes with it. I always look at an Achilles on what would I do myself, and I would fix it. And so that's why I always fix them.
So you would agree with me, and we can argue next on invasive together then?
Yeah, but he has a lot more data than I do. I mean, that's the hard thing. They've got a cohort of like 2,000 people that they've done non-operatively that have done very, very well.
It's hard to argue with the data, which is why I put this in here, because I think on the surface, if you asked anyone in this room, well, let's go ahead and ask. Anyone in this room, you have an elite level athlete who tears their Achilles. How many people are going to recommend surgery to their patient? Majority. And I would do the same thing because, well, here's the technique. We don't need to go through that. So one thing I do, I make my incision vertically. Maybe yours is a little different because I know it's smaller with the ultrasound approach, but the technique guides for this product says to make it horizontally. I just
And I completely agree, because when I used this and I made it horizontal, and then I realized that wasn't where I wanted it to be, then you got to make a weird L incision to try and get to it. Yeah.
100%. I don't know why they did it horizontal, but it should be 100% vertical. You can extend it proximally or distally if you need to extend your incision. And number two, it's not fighting against, if you think about, you make a horizontal incision and they're rehabbing and they dorsiflex, it's going to gap open the skin edges, whereas this one is not the same. So again, I'm not going to go through the technique there. Test your sutures intraoperatively. If they fail, you want them to fail in the operating room, not on the first post-operative visit or the first. If you have a lady that jumped off the table with her Achilles, had them repair, or at physical therapy, you do not want them to fail at those visits. You want them to fail right now. So I will stress those. I would pull those. If they're going to rip out, I want them to rip out right now. Same thing. How do you tension it when you repair it?
The angle of the dangle.
Just let it hang.
So we do a preoperative look at what the other limb looks like. I used to drape out both limbs and set it that way to, functionally tension it the same as the other side, but it's kind of a feel.
So this is the direct comparison of minimal invasive to non-op. So the re-rupture rate is the biggest concern, I think, and that's the thing that you sell your patients on. You could say, I don't tell patients what they should do from a surgical standpoint. I give them all the information. I say, here's the re-rupture rate if we do it this way. Here's the re-rupture rate, the complication rate. Obviously, you can't get a superficial infection if I don't make an incision. So what are your thoughts on, the data from Lyndon Mason's study with the functional rehab outcome? Are they good enough that we should be treating these non-op, or are you still going to stick with operative repair?
Currently, it's still still operative repair. And maybe because I always, we preach you should follow evidence-based medicine, and they do have really, really good studies, but there still is literature that supports a high re-rupture rate with non-op.
So you would have your own Achilles tendon fixed.
100%.
Do you think you are a high-level athlete?
Not at all. But I was still, because I had treated non-op Achilles tendons, it is a much longer rehab process. And if you can do it in a small fashion, if I have a surgeon wherever I am when I rupture my Achilles tendon, we do it in a small, minimally invasive fashion, that's exactly what I do.
So you can see here the post-operative incisions that come along with a minimally invasive Achilles tendon repair. You do a different technique than I do, but my technique has two different variations. One is where you put the jig in and you attach the proximal stump to the distal stump, tendon to tendon. The alternative option is to go tendon to bone. I'm going to let you answer, then I'll tell you what I do. You could probably.
We call it the Aaron Rodgers, or the Jason Tatum now, because he had non-invasive repair. 11 months after the Achilles rupture, I had a triple double. That's pretty impressive on what we're seeing. And I guarantee there's no NBA doctor that would non-op treat Jason Tatum.
Oh, 100%.
So there are some where I will reapproximate the tendon edges. More often than not, I am just taking proximal suture bite, getting a good bite, and I'm dunking anchors into the ankle. Most of my patients are larger. In the Midwest where we are in LaCrosse, and so heavy demands on weight bearing and farming and those type of things. And so I like to augment that repair. So I'll just talk to today. Achilles ends become reapproximating the heel on their own.
Yeah, that's what I would agree with as well. As there's not much of a debate because we are both correct. And so if we're both correct, then we can't argue the other side. But I do agree that you're going to take the tendon and reattach it to the bone. That's a much stronger construct to me than a tendon to tendon interface where you're just relying on suture tied together. That's not to me different than an open approach, except for the size of the incision. When you have tendon to bone interface, that to me is a much more reliable and strong construct, decreasing the ultimate reason you're doing this is to perform a strong, stable repair with early recovery and decrease the risk of re-rupture rate. And if you aren't decreasing the risk of re-rupture rate or decreasing the risk of complication compared to your open cohort, then why are you doing it in the first place? Any thoughts on that?
No, I agree.
All right, we agree to agree that. Any questions from the audience before we wrap this up?
Behavior and suture at bigger sites construct, so we both of that
So the question is for the podcast listeners, any thoughts to doing a combo repair of doing tendon to tendon and then tendon to bone as well? What are your thoughts on that? Overkill?
I think it's overkill if you're using the suture anchors. I think it's a very, very robust repair. But the other thing I didn't like about all the repair in was the suture knot management. That seemed that they always got inflamed at that rupture site for a long time because of the suture mass. And it just makes it less bulky repair. But there's nothing wrong with it. But particularly, let's say you get a large patient, kind of unhealthy, maybe you don't get to it acutely, that the tissue's not great, you do your end-to-end repair, you're not confident in it, then all right, augment it with some anchors.
Yeah, if you're Scott, for the same reason, if you're doing your tendon to tendon, you're having to tie sutures down, and those can be palpable on the surface. And you're more likely to get a soft tissue reaction. I have had a few people get a soft tissue reaction to that suture product. Yeah. And so the closer it is to the skin, in my mind, the more likely that I would have a soft tissue reaction, versus if you do tendon to bone, the way that you pass your suture from the proximal stump into the bone is going through the tendon with the banana lasso, and the suture itself is inside of the tendon as opposed to being surface tendon. There's still a little bit on the surface where you got to throw your sutures proximally that's coming down on the side, but not as much as if you were doing an end-to-end repair.
Yeah. Cheers.
Yeah.
How often are you converting these to like an open incision? One and then two. How often are you?
The question is, how often do we convert to an open, and how often are we augmenting with an allograft?
So minimally invasive, I haven't augmented yet. I'm still toying with my mind how I can make that happen, because I do think there's good augmentation options. I have not converted one to an open minimally invasive, but my partner did convert a minimally invasive to an open because he tested his anchors and sutures intraoperatively and they failed. So that's why Jeff said, make sure you test that repair before you leave the office.
So new literature shows 0.8% re-rupture with functional rehab. So if our big comparison was between the fix versus not fix, and all of a sudden with the correct the post-injury recovery protocol gets the re-rupture rate down to less than 1%, could you make an argument? At what point would you, with enough data and research, because that's what happens, we get enough, you're not sold on the MIS head bunion procedures, I'm not either, but enough data comes out eventually, you're like, okay, I guess you've shown that it's actually a reasonable thing. How much research would have to come out from this standpoint before you start to say, maybe I will treat it not?
Well, what's going to happen is this research is going to force our hand. This is what insurance looks at. And then all of a sudden, insurance isn't covering Achilles tendon repairs.
And then there's always the medical legal aspect of everything, because you did a surgery that showed had a low re-rupture rate. They got an infection or a soft tissue reaction. They needed more surgery. You had to breathe out half the tendon because it got infected. Now you're doing an FHL transfer. All of those things come along with the research. And so research to me is super boring, but it is what drives what we do, because like you said, insurance companies will look at that, medical legal will look at that, and it's just good standard practice of how you treat your patients based on the research that's available out there. Any other questions? Yeah.
You're like, how are you certain that they have avid acquisition here? And that's what they do, the tendon to bone repair, or you just trust that you brought down that practical stuff. Hard enough for you to re-ultrasound it?
You can, I re-ultrasound some of them. Because we have ultrasound when we use these just right there in the operating room. You can re-ultrasound. Again, it's not going to show up the because it's at the rupture site. You can see if you've gotten close enough. But most of the time, you're just guessing that, all right, we've kind of set a good tension. They're probably next to each other.
Question was, how often how do you know that you've reapproximated the tendon ends when you do your Achilles tendon repair? The answer is I don't care because of what he just said. You're reapproximating at the correct tension. And when the Achilles ruptures, it depends on when you get to it, it's going to have more and more contracture. And you're going to really fight to bring the proximal stump as distal as you may want. And so as long as you put the attachment of the proximal tendon tear into the bone at the correct tension, we know that these will heal in together, right? That data just showed that these patients will heal without any operative intervention. So eventually, regardless of us going in and put these anchors, the tendon will heal. To me, it's what, if you do non-op, what strength and how much resection or how much retraction that tendon occurred before before the mop bed started to heal in together. So the answer is I don't really care, and I'm not really had a problem with that. Could you ultrasound it and check? Yeah, okay, those are, but what would you even do? Like, let's say you put it the right tension and you see there's a 2 millimeter or a 2 centimeter gap, but you put it at the proper tension. Are you going to over tension it? I don't think so.
No, you're going to turn the ultrasound machine off.
You go home. I probably get some lunch. Yeah, so I don't really care where the tendon. Yeah.
You do know care that's already on these. Are you legit proximal stump or superplacement and the distal stump or superplacement designing in the middle of just proximal?
Just in the proximal and anchoring it to the bone. Any other questions? Yeah.
Was the level of the rupture matter enough to you? That one we can show is very rough. That energy.
Depends on the patient. Honestly, this was a college basketball player, so I'm going to tackle this via operative approach. Just in my mind, it makes more sense for a high level athlete. But the only thing that it changed was, if you look at this image here, I had to make these auxiliary accessory incisions halfway down because it's called a banana lasso because it's yellow. It's a suture passer where you stick it in the distal incisions, come out the proximal incisions. It's got a lasso. You grab your suture, pull it down. It wasn't long enough to get from the calcaneus all the way up to the rupture. So I had to make these accessory incisions on the side, bring it down to those incisions, and then go distally even further and then bring it up to those middle incisions and pass it all the way down. That's the only thing that changed with this very proximal rupture. But op versus non-op level, I think more about the patient and what their level of activity is. I really don't repair any Achilles tendon if the patient gets about 55, because they're not going to be an Olympian. Not that I'm treating Olympians, but Olympian or a high level, whatever, and their functional requirements are a lot lower than a college person maybe. Do you have an age cutoff for who you will fix? Or are you just judging based on their activity level, or how are you determining?
It's functional status and comorbidities. Those are the ones I did not treat all.
Do you have an age limit? You're like, well,
I don't have an age limit. It's just really what are you, not age, but how much activity, what do you want to do in life, and what are your comorbidities?
Yeah. Any other questions? Yep.
Like diabetic patients, I know not all of them, but I got aren't you going all about ulcers?
Calcaneal gate with them, right? Yeah. That's the one thing I wanted to see that. So she's asking about diabetic patients. Do you worry about heel ulcers after a non-op because you can't, they heel lengthen, you get a calcaneal gate. So the diabetic comorbidity, that's one of them that I won't treat operatively if they have uncontrolled diabetes, because you just open up wound issues are going to be bad. I keep them in plantar flexion longer to just really try and effectively shorten that healing of the tendon to make sure it doesn't lengthen out.
Any other questions? Well, thank you guys for the opportunity to do the Paw Patrol podcast. If anyone would like to hear this again, subscribe to Paw Patrol podcast. You can check it out there. It has been very humbling to be recognized, and I go to Act Fast if people want to take their picture with me, which my wife thinks is absolutely bonkers and weird, and I kind of do too, but it's very flattering. So thank you for the opportunity to come and spend some time here at the meeting. This is fantastic. It's not too far away from me in Iowa. And thank you to Scott for pinch hitting for Brad, who was too scared to come up and debate. So thank you for your time tonight, and thank you everyone for having me.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.